Good morning, everyone, and welcome to ASCO's virtual roundtable. Today's event, From Diagnosis to Treatment, Ensuring Equity in Precision Cancer Care, brings together experts and thought leaders from oncology care, clinical research, and patient advocacy. And we're so pleased to have them, and we're so pleased to have you to join us for this event. I'm Dr. Lori Pierce, and I am president of ASCO. And I will introduce you momentarily to our exceptional speakers. But first, I'd like to share a little background for today's event. As an oncology community, we have seen incredible progress and advancements in cancer treatment, and precision medicine has been at the forefront of this progress. According to NIH, more than 250 targeted therapies have been approved for use in cancer treatment by the FDA since as of April of this year. These therapies act on specific cellular mutations, unlike standard chemotherapies, which of course act on all rapidly dividing normal and cancerous cells. We've also seen the development of multiple immunotherapies that effectively stimulate the immune system to fight cancer cells in some patients. These very hopeful and sometimes curative therapies are no longer the exception. They're becoming the standard of care for a large and growing share of cancer types. So for today's program, we want to consider precision medicine through the lens of disparities in cancer outcomes and inequities in cancer care. My theme for my ASCO presidential year has been equity every patient, every day, everywhere. Equity is, of course, so important to all of us as we observe the one-year anniversary of the death of George Floyd. And achieving equity, health equity, has been a long-standing personal commitment for me. And this focus includes working to achieve equity in precision cancer care so that all of our patients have a chance of the best possible outcome for their disease. We see disparities at every stage of the cancer care continuum, from prevention to screening, diagnosis, treatment, and survival. And there's a real possibility that we'll see these disparities exacerbated with the increased use of precision medicine. And that's a very serious concern for cancer providers and for patients. So to help discuss these issues, I'm so pleased to be joined today by a remarkable group of experts and thought leaders who have devoted their careers to improving cancer care in underserved communities. Collectively, we plan to take a deeper look at the disparities in precision cancer care, share insights from frontline and firsthand experience, and then identify what more can be done to address this pressing issue. To lead us into our discussion, to kick off this discussion, I am very pleased to share my recent conversation with Dr. Otis Brawley. Dr. Brawley deeply regretted that he could not join us in person today, but I had the privilege of speaking with him recently regarding his views of achieving equity in precision medicine. Dr. Brawley really requires little introduction, as he is one of the most recognizable faces in oncology. He served for many years as the Chief Medical Officer of the American Cancer Society and is now the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. Dr. Brawley also has a long commitment to improving equity in cancer care, and he has spoken boldly over the past year about his personal experiences as a cancer physician and as a Black man in America. So he and I spoke last week, and I'm pleased to share highlights from our conversation. So Dr. Brawley, it is so good to see you again. You and I have known each other for many years, so very happy you could be here today. And thanks specifically for coming to talk about precision medicine and how it offers hope and promise to many patients with cancer. But at the same time, we know that racial and ethnic minorities, low-income Americans, the uninsured, those living in rural communities, and those who are marginalized are less likely to be offered genetic testing, less likely to undergo genomic assessment of their cancers, less likely to receive a targeted therapy, and also less likely to be enrolled in a clinical trial. So the issues of inequities in precision cancer care, they're complex and they're multifaceted. And we know that lack of health insurance or inadequate health insurance are big problems. In some communities, there's clear mistrust in the healthcare system. And we know that longstanding structural inequities, including systemic racism, play a major role in reducing access to high quality cancer care, and that includes precision medicine. So I want to kick off our conversation, and I'm going to ask you somewhat of an unfair question, but what do you see as the biggest barrier that prevents many patients from equitable access to cancer care, to precision cancer care? And that includes the full continuum of diagnostics, clinical trials, and new precision therapies. What do you think is the biggest barrier?
Well, first, thanks for having me, and congratulations on a wonderful year as president of ASCO in a very difficult time.
Thank you.
The answer to your question is whenever we have an improvement in treatment for cancer or an improvement in screening or diagnosis, we create disparities. There's a group of people who get the advancement and a group of people who don't. Many people are not aware that the black-white difference in colorectal cancer mortality or breast cancer mortality didn't exist in the 1970s. It's only in the 1980s, after we learned how to screen and treat for those diseases, that we started having disparities between blacks and whites. As we move into an era of precision medicine, I think we're going to have the exact same thing. We're going to have a group of people who don't get these new wonderful treatments or don't get them as much, and a group of people who are more likely to get them. And I think part of the solution is to figure out how you get adequate care to all human beings.
So let's go with that a bit more. If you had the silver bullet, how would you make that go away? How would you address that?
Well, first, I would make sure that payment for healthcare was the same for everybody. I think of Medicaid as a form of institutional racism. There are hospitals that will not take Medicaid, and they provide very high quality care. And there are hospitals that do take Medicaid, or doctors who take Medicaid, and they're overrun and overwhelmed and are resource challenged because they have chosen to help people out who are poor. Poor Americans end up in hospitals that have scarcity of resources and cannot provide cutting edge care the way hospitals that only take private insurance have.
Right.
There's a wonderful study from California a few years ago that looked at blacks and whites for colon cancer. And it found that in California, the majority of blacks only have 6 lymph nodes resected out after a colon cancer surgery, whereas the majority of whites had about 18. It's not that pathologists are racist. It's that the pathologists working in the hospitals where most blacks get treated had 5 or 6 cases to deal with per day. The pathologists working in hospitals where whites were treated had 1 or 2 cases to deal with a day and had time to dissect out the 18 lymph nodes. And so I'm very concerned about where we get care, how care is being paid for, and I'll get back to one of my original points. The greatest question that we can ask in cancer control is how can we get adequate health care to all Americans? One thing I would do is try to make sure every patient had some type of navigator or advocate, because so frequently the problem for healthcare, rich versus poor. This is more than black and white. This is really rich versus poor. The problem is that people who are less educated or less sophisticated in medicine have difficulty getting into our system and difficulty navigating our system.
I'm going to change topics a bit, and let's focus for a minute on data and its role in precision medicine, cancer care, and patient outcomes. We know that data can only tell us the stories of patients who are included in each data set. So the data are only going to be as good as the variety of patients who have been included in the data set. And we know that the data we have, whether from clinical research or real world data from EHRs or genetic screenings, are just not very representative of diverse populations. There are efforts underway to try to address the issue of improving our data. For example, NIH's All of Us initiative is aimed at building one of the most diverse health databases to expand our knowledge of precision medicine approaches. And then ASCO's own TAPER program is learning about how patients respond to precision medicine therapies in real-world settings. And there's a lot of momentum to remove barriers, such as restrictive eligibility criteria requirements. We're trying to do a lot to make eligibility more open for clinical trials, especially for industry trials that have very low rates of minority participation. So I've listed some of the things that we're doing, but What else should we be doing, in your opinion?
Wonderful what we're doing, but we do need to do more. We need to get more people involved in looking at some of these genetic studies. For example, I'm very concerned, not that drugs don't work in Black people, but people of African descent, and I prefer to use that phrase, are not being studied in terms of markers for activity for some of our new precision drugs. They're not being studied in terms of markers to assess how disease is reacting to treatment. And the end result is we may end up with increasing the disparities. I've frequently said race doesn't matter biologically, but race matters socially. And I still believe that very much so in the United States. But as we start looking at genetics, we do have to look at ancestry and we have to look at area of geographic origin, not necessarily race per se, because I've got examples of how genetics can actually be the same in people of two different races and not be the same in people of the same race. So we have to be very careful. We need diversity of populations by area of geographic origin, not as much diversity by race.
So last year you wrote a piece in the Cancer Letter, beautifully done. And in it you said to categorize the population by race is like trying to slice soup. And I've spoken along similar lines. I haven't used that line about slicing soup, but similar ideas. There's such admixture among populations that it just can't be done. So what advice, Dr. Brawley, do you have for clinicians and researchers who want to tackle racial injustices? For example, by enrolling more diverse populations on clinical trials, but don't want to reinforce false beliefs about racial categories?
Yeah. Thank you for that question. Race is such a broad category. You know, when we look at white, the people who do ancestral anthropology and ancestral genetics tell us among Europeans, there are 600 plus areas of geographic origin. White is not just one thing, it's 600. In Africa, it's at least 110. And it's only 110 known in Africa because Africa hasn't been studied as well as Europe. Okay, so race encompasses a lot of things. Now, if you're a doctor taking care of a patient in front of you, the most important thing to do is try to relate to that patient and that patient's needs.
So before we wrap up, what's the one thing you'd like our audience today, and in fact, the larger cancer care community, to take away from this conversation?
If we provided adequate care to include prevention, screening, diagnosis, and treatment to all Americans and had been doing it over the last 30 to 40 years, of the 600,000 who are going to die from cancer this year, we estimate about 130,000 would not die. Disparities is that big. It's 23% of all cancer deaths are avoidable if we simply applied what we have now. That's not a new treatment. It's not a breakthrough treatment. That's just apply what we have now from prevention all the way through treatment. Now, of the 130,000 or so, 80,000 are white. The largest disparate population in the United States are white Americans. Sure. They, by the way, tend to live in the South, and they tend to live in states that have not extended the Affordable Care Act. So while I criticize Medicaid, I realize that Medicaid has helped somewhat, but we can do better. And if we can get doctors to really try to think about their patients and think about their patients' social circumstance, we can actually improve our circumstance and decrease the number of deaths that are occurring due to disparities.
Every patient deserves equitable care, and it takes a village to achieve this. This has been a great conversation. On this note, I'll have to end by saying your comments were enlightening as always and very much appreciated. And thank you so much for joining me today, Dr. Brawley. I've really enjoyed this conversation. Thank you.
Well, thank you, and thank you for all that you've been doing.
So thank you again, Dr. Brawley. So it gives me great pleasure to now introduce our three esteemed colleagues that will join me to focus on the first panel, Leaving No Patient Behind in the Era of Genomic Testing. Dr. Fumi Olopati is the Distinguished Professor of Medicine and Human Genetics at the University of Chicago. She is the founder of the Clinical Cancer Genetics Program at the University of Chicago Medicine. She also co-founded Cancer IQ, a company that helps providers use genetic information to prevent cancer across populations in urban and rural settings. Ms. Isabel Duran is President and Executive Director of the Latino Cancer Institute. An award-winning journalist, Ms. Duran is also a cancer survivor, and she works closely with underserved patients. She has long advocated for the establishment of a Latino genetic registry, and she worked to develop a genetic training program for community health workers. And Dr. Blaise Polite is a gastrointestinal oncologist and professor of medicine at the University of Chicago. Dr. Polite's research focus is cancer health disparities, and he also has extensive Capitol Hill and policy experience. He's a dedicated ASCO volunteer who has served on its board of directors, has chaired its health disparities and government relations committees, and most recently, he has served as a special editor for the JCO Oncology Practice Special Series on disparities in cancer care for Black Americans. So welcome to all of you. Thank you so much for being here today. And I want to start by discussing the barriers some patients face in receiving a timely and complete cancer diagnosis, which of course is the crucial first step for any patient. Before any individual is even considered for a targeted or precision therapy, he or she must be screened for cancer. And then if diagnosed with cancer, their tumor must be tested for relevant biomarkers, which of course are the genetic mutations or other characteristics that are going to be targeted by the precision cancer treatments. We know, however, that some groups of patients are less likely to receive a complete diagnosis than others. For example, there was a recent study looking at Black patients with non-small cell lung cancer, and they were less likely to have their tumors tested for EGFR mutations than did white patients. And not surprisingly, they were less likely to be treated with EGFR targeted therapies. So we know that there are problems, but I don't want to just talk about problems. We need to find solutions, real solutions, to ensure that all patients receive the right screening and diagnosis. So I will start with Dr. Olopati. My first question for you: what constitutes the standard of care for a complete and timely cancer diagnosis in today's era of precision medicine, and what should patients expect to know about their disease?
Thank you, Dr. Pierce, for that, throwing the first question at me. As you know, what's really important is that we're talking about cancer, a disease that kills millions globally. And yet, before we can treat cancer as oncologists, we have to know what we're dealing with. And so for a very long time, we had always talked about risk-adapted treatment. And now you cannot do that without actually having a marker to go after. We have made significant progress. You started off by saying there are more than 200 drugs that are in development. And yet, I look at the average person, whether they are in downstate Illinois or they're in northern Indiana, when they hear the word they have cancer, the first question is, that's a death sentence, right? But we've moved the needle, like my brother Otis Brawley said. There didn't used to be a disparity when we didn't have effective therapies. So now what I'm saying is that everyone, doesn't matter where they are, when you get that word, you have cancer. Cancer is not one disease. In my field with breast cancer, I know I have to know about, is it a cancer that is HER2 amplified where there are targeted therapies? Like you said, is it one where I have to target the estrogen receptor? So it's very important to say, what type of cancer do I have? even when it is metastasized, we're finding drugs that can actually get cancers that had spread everywhere to melt away. So the standard of care should be, tell me I have cancer. But the second question is, what type of cancer and what drugs would target the type of cancer I have? And that should be available to every patient everywhere. That is what we mean by making it personal to you. And so the drugs are there, whether you have a family history of cancer, whether you don't have a family history of cancer. The first question should be, what type of cancer do I have, with a biomarker to tell the doctor how to treat that cancer.
So a perfect segue to a follow-up question, which I think you really kind of touched upon. How does lower use of biomarker testing to identify these genetic characteristics of a patient's cancer lead to unequal access to the latest treatments for minorities?
Absolutely. So when we started clinical trials of Herceptin in the 90s, I would get Black patients, and I'm going to use the word Black patients because I'm a Black doctor, and a lot of patients come to look for me at the University of Chicago. They will come from Northwest Indiana to participate in our clinical trials. And guess what? Some of those patients who had advanced metastatic breast cancer in the 90s, they got Herceptin and their cancers went into complete remission. Some of them have been on treatment now for the last 16, 17 years. That was the death sentence that we used to want to do more for in those days. And now we're talking about de-escalating, that some of these patients may not even need chemotherapy because of the advances that we have made. And so that's why it's really important. If we're not going to say Black or white, then let's talk about what is the genomic marker for my cancer. Will it make me avoid chemotherapy, or does it allow me to get even more so that I can be cured or at least have my cancer go into remission? So that's why it's so important that we have this diagnostic test available in every community. And I think the assays are now available because we've learned from this pandemic that unless you get a COVID test, you're not going to know that you have COVID. So all those tests that we now have in communities can be used to actually now expand access to diagnosis, and the appropriate diagnosis that is biomarker informed will surely allow every patient everywhere to gain access to precision oncology.
Thank you so much. So I'm going to move to Dr. Polite. And Dr. Polite, you wear multiple hats. So the first question, I'm going to ask you to put in your clinical hat. What do you feel are the major barriers to receiving a complete diagnosis, especially for Black and Latinx and other people of color? And how do these barriers translate into poorer outcomes?
So, Dr. Pierce, thank you. And thank you for your leadership this year as ASCO President, and having Dr. Olapade, yourself, and Dr. Brawley. I know that I stand on the shoulders of giants, and you three are certainly among those.
Thank you.
You have to go back and what Dr. Brawley, has taught me over the years, and I have seen with myself, is we don't have a healthcare system, right? We have a fragmented system of care. And so what you find is that many patients, Black patients or patients who live in lower resource settings, are not connected to a comprehensive set of care. So they may be in a federally qualified health center, and they may get diagnosed with their colon cancer there with a fecal blood test. Then getting those folks to a colonoscopy at a major center becomes a major barrier. Once they're diagnosed, getting them into a system becomes a major barrier. And no one along the way is really trying to figure out where these patients are at any one time. I mean, I've often said and written, I know at any time where my Amazon package is. I can tell you exactly where it is, at this moment. But I can't tell you a patient who's had a positive FIT test. Have they gotten their colonoscopy? Are they scheduled for it? If not, why not? What are the barriers there? So to me, it's fragmentation of a system that people are not connected in with sort of larger health centers that can do this sort of comprehensive care. And, then the second thing is, again, navigating people through that system and then holding ourselves accountable for patients who are falling through the system. So you see a theme of mine is, if we are serious about health equity, then health equity should be an outcome metric that we pay attention to and that has consequences if we don't meet it.
Excellent response. So that was with you wearing your clinical hat. Now I'm going to ask you to put in your policy hat. And I want to turn to screening. We know that in many minority populations, patients are diagnosed with more advanced stage disease, and they often have more aggressive forms of cancer. What do you think can be done to ensure these individuals receive cancer screenings early enough to improve their outcomes?
So I'm fortunate enough to be, a co-PI in a moonshot grant here, where we are working with federally qualified health centers to try to get colon cancer screening. And what we find is, yes, number one, there are a lot of just practical barriers at the centers themselves that we're trying to fix. But the piece of data that I've seen that shocks me, right, is that, patients with a positive FIT test, right, so these are patients that have a high likelihood of having cancer. On the order of about only 20 to 25% of them can we find any evidence that they've had a follow colonoscopy. All right. So just like, vaccines don't save patients, vaccinations do. Screening tests don't save you unless you actually follow through, get the diagnosis, and get treatment for it. So from a policy standpoint, what I have advocated for is, I think Medicaid programs, and specifically the managed care organizations that, now provide the predominant care for Medicaid patients, these health equity outcomes should be a major metric for them. And states should be using those metrics to decide where they're sending patients, right? So states have a choice on how they set up panels for the different managed care organizations. So you shouldn't be getting more Medicaid patients if you're failing to achieve health equity outcomes. Similarly, I think the federal government, which is paying, 55 to 65% of the bill for Medicaid programs, should also use that leverage to have health equity as a metric. So to me, the first thing you do is you say, here's how we expect you should do, here's how you're actually doing, and you need to improve and figure out how to improve if you want to receive funds and if you want to expand your patient base. So, again, my overall theme from a policy and from a clinical standpoint is, if we're serious about health equity, then make it a major priority and make it a major metric for how we assess, is care being provided. Until we do that, then it's just talk. We all feel bad about it. We wish things were better. We hate our healthcare system. Incentivize it, make it a high stakes metric, and I guarantee you people will find solutions, because there are solutions to this, right? This is what drives a lot of us crazy, is there are successes if you care and if you prioritize.
Those are very thoughtful remarks. Thank you very much. Ms. Duran, we know the social determinants of health have a significant impact on cancer survival rates and outcomes. And from your personal and professional experiences, both as a cancer survivor and a patient advocate, please talk a little bit about some of the hurdles that you see people of color, people in communities of color and immigrant communities, what they face when they receive a cancer diagnosis, and help them to understand their cancer diagnosis.
Thank you, Dr. Pierce, for inviting me to join you. Dr. Polite is singing my song. These are issues that we have been addressing. I have been working in the cancer arena for about 20 years now, since my own diagnosis. Let's talk about one community specifically. We're talking about the Latino community, which is 60 million strong in this country. And about 40% of that community is immigrant, with varying degrees of status. So when we try to do our work, we obviously try to reach out to those who are most disadvantaged, those who have the least amount of care, and those who will fall through the cracks. According to American Cancer Society, 1 in 5 Latino deaths are due to cancer. It is the #1 cause of death in our community. Breast cancer is the #1 cause of death amongst Latinas. And although disproportionately smaller to Black and white communities, cancer is cancer, death is death. And as Dr. Olapandi said, that word drives such fear in communities who live with misinformation, disinformation, and don't even have access to standard care much less quality care and all
Right.
that precision medicine is supposed to bring, right?
Right.
When I was diagnosed, and I worked in television for 43 years, and 30 of them at the time I was diagnosed here in the San Francisco Bay Area. And my oncologist on my first visit said to me, "So how do you want me to treat you? Like a patient or a celebrity?" I didn't realize there were different ways of treating patients. I found that very interesting, but I thought, shouldn't all patients be treated like celebrity? Isn't that precision? And I know he was well-intentioned, but that was the point. And then I heard Stanford has concierge services. What do those look like? And do poor people concierge services? In immigrant communities, they need knowledge and awareness. Then they need access to standards of care. Then they need to work in systems that actually are integrated from the federally qualified health systems into public healthcare systems through comprehensive cancer systems where they have all of the sophisticated and advanced diagnostics. But first, they need to understand it. They need not to fear it. They need to utilize early screening for intervention, which is why I worked on a genetic breast cancer toolkit with a colleague of mine at UCSF in order to introduce communities of color, but in this case, Spanish speaking, which is the other problem, the language.
Right.
That is one of the huge barriers. And that is why I said, let's introduce the community to the concept. So let's remove the fear. And then we can increase awareness, and then we can move them into systems. And that's where we need navigation. So thank you, Dr. Polite, for mentioning that, because it is so crucial.
So there is so much I want to follow up on. There's so much you just said, and you touched upon some of the things that I want to ask about. What services, tools, and resources do you believe are most effective in helping patients overcome barriers, such as speaking a different language, which is what you mentioned, lack of transportation, childcare, other factors related to where people live and work? How can we overcome these barriers?
Invest, invest, invest.
Yeah.
We need dedicated dollars to invest in community-based organizations, which are utilized by all of our communities in order to address the disparities. We can't wait for systems which are truly broken, which have huge cracks, and which some of our immigrant communities said, we cannot go back to normal because normal is what got us here in the first place. And they're looking for shifts and changes in order for them to be part of this humanity and not a side of the humanity. In fact, I remember one immigrant woman saying, our services are essential, but we are not. They recognize how flawed systems are. So anyway, let me not get off track, but these are person-to-person issues.
Mm-hmm.
Navigation along the cancer continuum. So utilizing community health workers through community-based organizations to come to help them move through education and awareness into early screening through understanding testing and precision interventions like genetic testing for breast cancer, for BRCA, et cetera, or for colorectal screening for potential Lynch syndrome, multiple kinds of testing that they say, what is that? How much is it going to cost me? Where do I get it? And then you need physicians at the clinic level who actually understand what to do with the data, what to do with what they just got. We need insurance companies to pay for those tests. We need inclusion in clinical trials to figure out what medicine works and what doesn't work. I think Dr. Brawley pointed at that. There are not enough of us included in clinical trials to understand that even in subpopulations of Latinos, from Cubans to Puerto Ricans to Mexicans, there are differences. There are a lot of differences in why, Cubans actually have a higher rate of colorectal cancer than Puerto Ricans, than Mexicans. So I'm sorry, there are just, as you said, there is such a deep complexity to the answers to these questions. But we need to start with our most disadvantaged first. And I think that we figure out with communication, with community-based organizations and collaboration, we can begin to create that seamless experience across the norm. And then we have fabulous collaborators like Dr. Olapati and Dr. Polite who understand this and who will do all they can within the systems to help us get it right.
So I want to ask one more question, Ms. Duran. I want to talk about mistrust. Mistrust and fear of the healthcare system among certain populations, we know is a known factor rooted in discrimination, and we know it still happens today. So I would be very interested in your thoughts for what should physicians and other healthcare providers do to build trust with their patients? And you've already touched a little bit about community outreach and its impact, but talk a little bit about mistrust and what physicians can do to make that much less of an issue.
Well, I think first of all, in particularly immigrant communities, and I don't care what color they are, there are many peoples in immigrant communities who feel very traumatized by actually the federal actions of the former administration that not only widened the gap in their access to care, but it also sent these these messages that said that if they took advantage of anything, they were going to perhaps lose a path to legalization called the public cause, or public trust, or public use. And there were many who even during COVID didn't want to get tested because they feared it would be turned up on their records and that would count against them. So they're not trusting what they hear from hospitals because they seem to be extensions of the government. These are systems that have never seemed open and welcoming. So we have people going into systems who say, yes, I speak English. And then when you ask them, their preferred language is Spanish. So you know that they're getting maybe 1/3 of the care and understand 1/3 of what the doctor is saying to them. So, and we had a colorectal cancer patient who was terminal that we were navigating through the system at the public healthcare hospital, which has a cancer center. And I said to her, out of all of the things that our navigator has done for you here, Spanish-speaking navigator, taking care of 1,000 Spanish-speaking cancer patients over a 10-year period, she said, out of all of the things she has done for you, which makes the biggest difference? And she paused and she thought, and she said, she speaks my language. Is not language the soul? And if you can't talk directly to your doctor,
right,
share that fear that Dr. Olopati talked about, share the concern. You can't bring your family with you. You can't share that burden. You don't know what to do, where to turn, how do you pay for the drugs? All of this creates that sense of mistrust. I don't know who to trust. I don't know who I can embrace. I don't feel welcomed into these systems because they don't speak my language. They don't understand me. They know where I come from. They don't know who I am. So I wished it was a simple single answer. It is not. I think we all have seen that, just the idea of addressing the policy. I love what Dr. Polite is talking about in terms of structural shifts and changes. We are here at this intercession in this moment where we think we have a moment to maybe get some changes, but it depends on all of us, as you said, Dr. Pierce. It takes the village. And if we're not all pushing the right way in the right direction, I think we will be on the other end of this at the same place with a lot of frustration and unequal care.
Your comments are so important. And actually the idea of mistrust is so important. I want to ask Dr. Olopati, and I'm also going to ask Dr. Polite about this. So Dr. Olopati, from a physician's perspective, how does trust between a patient and the career care team improve the cancer experience?
Yeah, so thank you for asking that question about trust. And you know, what this pandemic has actually showed us is that we can believe in science and we can trust our doctors. And I really just want to say to everybody out there, whether you are Latino, Latina, Black, white, Asian, you know, we are all in our own tribes and we are all in our own communities and we see what we see. But, you know, the World Health Organization said something and did a clinical trial on solidarity. And I hope that today, that is what we will leave this panel with, is that we all have to be in solidarity. I have not met any doctor who went to medical school without a heart to take care of their patients, right? There are just not enough Black, Latino, Hispanic, Cuban doctors to take care of every Cuban patient. And that's why part of my job at the University of Chicago is to make sure that we train all of us to be in solidarity with all of our patients, who come from very different backgrounds. We can learn to show empathy, but we also can learn to deliver the right drug at the right time for the right patient. So what I think we should be talking about now to bring us to this equitable distribution of resources and to bring us to health equity is what Dr. Polite said, right? These drugs are there. Let's take them to the community, right? Let us have a doctor who speaks and sees patients in the Asian community, who is in Chinatown, to be able to have access to the same drugs and the same clinical trial that my patients come to me at the University of Chicago to obtain. And until we distribute all of this and build networks, right, we're not going to be able to get to equity. Because just as we talked about language barrier, there's also transportation barrier, right? If you can't travel to the academic center, you may not be able to get to the best clinical trial. So I think going forward, we have to trust that clinical trial participation is important to all of us. So in solidarity, we all want to be part of it. We want to tell pharma, don't bring all your studies to the universities. Take them to the community where the community will accept them. As my colleagues at the University of Chicago always said, you always have resources in every community. The problem is we're all gated in our elite universities and we don't get out there to meet people where they are. So I think in solidarity, for us to achieve the promise of precision oncology, we've got to meet community oncologists where they are, we've got to meet patients where they are, and they come in many very different shapes and backgrounds and culture. And once we respect the dignity of every human being, I think we can begin to build trust. We can begin to act in solidarity. There's so many who are in rural America who don't know what we're talking about in urban America. And we can't divide ourselves based on urban and rural. We've got to come together in solidarity. And I hope that that's what this pandemic allows us to do, where we begin to trust. And we as physicians, healthcare providers, we all have been talking about healthcare providers as heroes and heroines during this pandemic. You may not know who was taking care of you when you were in the ICU fighting COVID. The same thing. After this pandemic, it doesn't matter whether your doctor is Black or white or Hispanic. Let's build that trust that enables us to bring solutions to the table and be active participants in our own care.
So we've quoted Dr. Polite many times, but I want to just go to him. How do you bring trust into your relationships with your patients? How do you foster trust?
So I have a slightly different take on trust, and I have a concern with the way trust gets thrown around. There's no question we have a healthcare system that was built on a foundation of systemic racism. We know that. I work at a hospital that has, to put it nicely, a complicated relationship with its surrounding Black Southside community. However, what I often find trust gets translated in is it's a patient problem. Why don't Black patients go on clinical trials? Because they don't trust the system, because of Tuskegee, et cetera. When you actually look at the data, right, what do the data show us? The data show us that why don't people go on clinical trials? Number one, because the places where people go don't have clinical trials available, right? Number two, because they're not eligible for the trials because of all the work that you've done and you've championed in terms of changing the eligibility. And number three, we don't offer the trials to Black patients at the same rate we do white. And when we do offer trials, Black patients go on either at the same number or often more often than, so I very much, the patients that walk through the door already in some degree of implicit, if not, somewhat guarded trust, in us. But if we actually then meet them where they are, often the trials do those kind of things, they will engage in care. So I always worry that trust ends up being blaming the patients and the communities for not engaging in care, rather than blaming us for assuming it and not providing equal care.
Those are excellent points, and I agree with all the points the panelists have made. They're excellent points. So I guess we need to see if we have questions from today's attendees. I want to take a few minutes to be able to answer questions from the audience. So I'll turn it over to Jeanette if there are questions.
Thank you, Dr. Pierce. We've had a number of excellent questions come in through the chat panel, and I'm going to try and merge a couple to see if maybe we can get some answered through one question. Just building on some of the comments from Dr. Brawley, Dr. Olapati, and Ms. Duran about the differences within the Asian community, and instead of lumping them together as a whole, or even Hispanic Latino community, knowing that there are differences in rates of different types of cancers, how can we begin to separate out those discrete populations and make sure that they are counted in order to ensure that those patients are in fact getting the right screening and the right drug for them?
Yeah, the reason why I do global oncology is because I have deep appreciation that America is an immigrant country. We all come from somewhere, and our ancestry is where the genetics come from. And so we can't divorce that from who we are now once we've migrated or we're now settled in America. And I think that the International Agency for Research in Cancer and the Global Cancer Observatory, they've made it clear that, in fact, zip code by zip code, we have to count where people live. Who lives there? What are the toxins? What are the waste? What are the environmental challenges that actually increase cancer risk in some populations? And so without thinking about geography and the diversity of the geography and toxins that people are exposed to, we will come to the wrong conclusions in terms of our interventions. So I really appreciate that question, because we have to count. Everybody counts and everybody matters. And I think as we begin to think about being in solidarity, as ASCO moves from being an organization that is focused on US oncologists and now begins to embrace the fact that we have oncologists and we have cancer researchers all over the world, we have to think about where the data are coming from, what the questions are that these cancer patients are facing in their own communities. And I think as countries are investing more in building the infrastructure to support cancer patients in their own countries, in their own communities, I think we'll be able to resolve some of the challenges we have when we lump everybody together. Lumping is good at the higher level, but it's also important for precision oncology to take it down to that individual in their own zip code.
Thank you, Dr. Olapati. Jeanette, we can take a second question from the audience.
Doctor, could I respond to that as well, Dr. Pierce?
Absolutely.
What I have tried to do at the policy level is to make sure, first of all, discussing changes in federal regulations that leave out the undocumented and the uninsured from participating in clinical trials. The second thing I have done sitting at the IRB for the All of Us research program was to insist that every research application show us a plan of inclusion for and metrics of how they're going to achieve equity in the footprints where they serve, how they have inclusion, really holding researchers' feet to the fire about equity and inclusion. Done the same thing here in California at the stem cell level, in which we're requiring that clinical trials have an inclusion path, that they demonstrated, and that they could be graded on that. That is as equal a thing as the sciences, because good research is just JUST research, and inclusion is part of that justice. And so those I'm trying to address at that policy level, because that too is going to have a major impact about us coming up here. And so from grassroots to grass tops and grass tops to grassroots.
Excellent. Thank you. Jeanette, do we have another question from the audience?
If we have time for one more, maybe this might be for Dr. Polite. There was a question about, the ability for general oncologists, which tend to be the ones that are serving in those hospitals, seeing those underserved patients, and their ability to stay up on the late breaking in each disease site, and how that might be contributing to disparities, and whether specialty oncology training is actually the future to address that.
Well, I think the reality is the majority of cancer care is going to be provided by generalists in the community. If you talk to community oncologists, they like being generalists. They actually don't want to specialize in one disease. So then the question becomes, how do we as an oncology society help them to deal with this complexity? So, if you look at things like Cancer Link, which ASCO has been working on for many years, which tries to give information for how do you treat the patient in front of you. If you look at things like care pathways, which is something I've been advocating for, a long time, and making oncology, value pathways being a predominant form of the way people practice. This is what we've instituted for our community oncologists, so that if you have the patient in front of you, you see their molecular type, you can see how experts in the field say this patient should be treated. So I think instead of trying to change the training and make everybody, specialists out there, because good luck doing that in rural communities in Iowa and other places, we need to make sure that as a society, and this has been an ASCO focus, I mean, there's no question about it, is that everybody has at their fingertips in this world of, global information, patient in front of the patient, what the correct way to treat that patient, what molecular information do I need to even navigate the pathway, and that's how we assure it, and then hold us accountable for actually doing that, right? So that becomes our quality metrics, give people the resources and the tools to take care of the patient in front of them. And that's worldwide, right? So somebody practicing in Sudan, in Nigeria, or practicing in Chile or Argentina or anywhere else in the world should have access. There's no reason they can't have access to this information and know how an expert in the field would treat the patient in front of them.
Yeah, I just want to make sure that I add to that, because as we train the next generation of diverse students to come into oncology, as the field rapidly expands, there's no way any doctor can keep track. And that's why we've got to build the infrastructure, the platform to support oncologists wherever they practice. And as you know, when we started talking about genetic testing in 1997, ASCO created the Cancer Genetics Task Force and said oncologists should know how to take a family history and then order genetic tests. And they've continued to support practices to know how to do this and how to interpret. Then we were testing for one gene. In the future, we're going to be testing the whole genome.
Right,
so
right.
Nobody's going to be able to know this. And that's why the academic community partnership must grow. The academic patient partnership, building more in the communities, is the way to go. And I think this is the knowledge age. We can do this. And I think with getting real data from everywhere, we can do this in solidarity.
So on that note, what a perfect segue to end our panel. Dr. Olopati, Ms. Duran, Dr. Polite, I thank you so much for joining us today for this amazing discussion. There were so many more questions that I wanted to ask, but we ran out of time. So I think we can all agree that there is much that can, should, and needs to be done on this front. And I thank you so much. So we're now going to shift gears and move to our second panel, focusing on access to precision cancer therapies. And for this discussion, it's my pleasure to introduce Ms. Sybil Green, ASCO's Diversity and Inclusion Officer, who will moderate our next panel. Ms. Green is a healthcare policy expert with extensive experience in the government, corporate, and nonprofit worlds. And she guides ASCO's internal and external initiatives aimed at achieving the society's equity, diversity, and inclusion goals. And I will turn it over to you, Sybil. Thank you.
Thank you, Dr. Pierce. And oh, how I wish we could have continued that discussion because it was so rich. But we have an opportunity now, and I'm pleased to introduce our next panelists. There are three leaders in precision cancer care, cancer research, and health policy who will discuss barriers and solutions to accessing equitable precision cancer care medicine. Today, I will have the pleasure of chatting with Dr. Sherry Gleed, who is Dean of New York University's Wagner Graduate School of Public Service and has served in key leadership positions with the Bush, Clinton, and Obama administrations. Dr. Gleed is a nationally recognized voice, expert, and researcher in the area of healthcare reform. We also have with us today Dr. Manali Patel, who is a medical thoracic oncologist and health services researcher at the Stanford University School of Medicine and the Veterans Affairs Palo Alto Healthcare System. Dr. Patel's experience lies in designing, implementing, and evaluating new models of care, delivery aimed at achieving cancer health equity. She's chaired ASCO's Health Equity Committee and has been a leader in addressing disparities across the care continuum. And finally, we have Dr. Carmen Calfa, who is a breast cancer medical oncologist and an assistant professor of clinical medicine at the University of Miami. She is the Sylvester Comprehensive Cancer Center's principal investigator for ASCO's TAPER trial and works as part of a multidisciplinary team of cancer experts and researchers. So good afternoon and welcome to you all. Thank you for joining us. We'll shift our focus now to equity on the treatment side of precision care, which came into the conversation a little bit earlier, but we have an opportunity to really dive in now. So in other words, once a patient is properly diagnosed and their relevant biomarkers are identified, how do we make sure they get the right treatments? And that's treatment without delays, interruptions, or avoidable complications. And as with cancer care overall, Black patients, Hispanic and Latinx patients, Asian Americans, and other disadvantaged populations are less likely to get precision treatments they need. So for example, in one study of women with HER2-positive breast cancer, only 56% of Black patients receive HER-targeted treatment versus 74% of white patients. So Dr. Patel, let's start with you. And let's start with cancer clinical trials. So we know that participating in a clinical trial is often the best treatment option for an individual with cancer. And yet we also know that racial and ethnic minorities, low-income Americans, the uninsured, and those living in rural communities are less likely to participate in clinical trials. So only 5% of clinical trial participants are Black, despite making up 13% of the population. So tell us, why is it important to increase accrual rates for these patients? And do you have ideas for recruiting a more diverse patient population into this research?
Thank you for asking me to boil the ocean in a couple of minutes. But as you know, and what we've heard from this really rich panel and the discussion with Dr. Brawley is that cancer care has really become incredibly complex, very personalized. Precision medicine has transformed and improved patient outcomes, but only for a subset of the population. We simply are not doing a good job of even providing basic cancer care. When populations are excluded from research, that research certainly may not benefit all of these populations. And it is imperative, therefore, that we really over-recruit historically excluded populations so that all populations can stand to benefit from the novel advancements in cancer, making sure that these are not only applicable, but also accessible to populations. I think, Dr. Polite mentioned if we're really serious about achieving cancer equity, my thoughts are we really must ensure that all populations can benefit from the research on which these advances are developed, which means that we must include all populations in this very research. In terms of approaches to increase diversity in our clinical trial populations, to make sure that these trial populations are representative, partnerships are really key. And you heard Mr. On discuss the importance of community-based organizations. In our prior work, we've really partnered with community-based organizations. We train community health workers to engage patients not only in their cancer care to ensure that basic care is provided, but also in helping to provide awareness regarding the importance of clinical trial opportunities and also education. We also partner with payer organizations prior to the Clinical Treatment Act, which just passed thanks to the advocacy of ASCO and many others, that now allows individuals to receive not only payment for usual cancer care services while on a clinical trial, but also opens the door for other, not only just Medicaid, but also for other payers to follow suit. We just published a study in the Journal of Clinical Oncology, Oncology Practice, that shows this partnership prior to the Clinical Treatment Act which was a partnership between a labor union organization out of Chicago. We trained the community health workers. We also designed payer benefits such that coverage of usual cancer care was covered. We also included coverage of social determinants of health, such as transportation and childcare, which we know make it impossible for patients sometimes to even receive care, much less participate in a clinical trial. And there we quadrupled the enrollment of historically excluded populations in cancer clinical trials simply by redesigning the process and with these partnerships. And one last aspect is really rethinking how we design clinical trials to make it easier for participants to participate. I think COVID has taught us many lessons, and one of which was that we can divorce aspects of clinical care from sites that are away and inconvenient from particular patients' populations, or actually all patients probably would prefer to receive care and some aspects of care in their homes. So why not rethink how to deconstruct clinical trials, take components which can be provided in patients' homes, make them more convenient so that the populations who we really want to include on these trials can actually participate. And that's really where the community-based organizations can help.
Thank you, Dr. Patel. I think what you laid out is a series of solutions that we can focus on in terms of the community, certainly getting the payers involved. And then finally, when we think about trial design, I want to throw it to Dr. Calfa to build on. And let's start with ASCO's TAPER trial. Dr. Calfa, I know that your institution is involved in ASCO's TAPER study. And just let me pause there because we use a lot of acronyms in healthcare. So let me define it. TAPER is the Targeted Agent and Profiling Utilization Registry, which is ASCO's clinical trial and provides access to FDA-approved targeted therapies to patients for whom standard anti-cancer treatment is no longer responding or for whom no standard treatment is available. And this is done at no cost to the qualifying trial participants. So Dr. Calfa, with your experience with the TAPER study, can you share some of the lessons that can be drawn from your experience? And specifically, tell us how we can expand patient access to precision therapies.
Thank you so much for having me. And I'm really delighted to be here today talking about these important issues. I'm really happy that ASCO has called for action and precision medicine and offering treatments that are in clinical trials or standard of care treatments, to every patient in our neighborhoods is really our mission. And I'm fortunate to be in South Florida, which is the melting pot for all minorities, and you can find a population as diverse as you like. So that made us, be positioned in a way that we actually can influence participation in clinical trials, and we can impact, the collection of the data from these minorities. So we take this mission very seriously. And when TAPER launched the trial, we're really in line to become a site in Florida, because, to really say a few things about TAPER, I think it's one of the best designed trials. I think it's one of the friendliest when it comes to investigators and to come to patients. And Dr. Shirsky and the team had done an amazing job in really making this trial easy to work with for everybody that is involved, including patients and physicians. I will share with you the fact that, so TAPER is now celebrated 5-year anniversary, and we have become a site less than 4 years ago. It's now open in 24 states, and it has about 129 sites. It had accrued about 2,000, give or take, patients, and they were about 3,000 patients that signed consent. So even though it's widely spread, when you look at the number of patients that are really taking advantage from a study that is so well done, it's really puzzling. I look at the numbers every day and I would say, well, everyone with stage 4 cancer from age 12 and above, solid and hematological malignancies, potentially should be looked upon for participation in TAPER. And not to say that TAPER is the only precision medicine trial. It's the dearest to my heart because I'm the PI for our site, but NCI has matched, and we're also fortunate recently to receive through the NCI designation that we have the catch-up grant, which is also looking to create access to targeted cancer treatments for those underserved. So we have a couple of options, including the phase 1 cancer agnostic trials that were really looking for every patient that has a next generation sequencing done either on solid tumor or on liquid biopsy to see if they're available or if they are eligible for a trial. So with that, I'm going to say that the lessons that we learned, a lot of patients that come to our doors don't know anything about NGS. They did not have it. From all the second opinions and patients that I see for first opinion, if they come with advanced cancer, the hardest thing to get a hand of is the NGS. And when I ask the patient, most of them don't know about it. So I see that as a huge opportunity to really bring it to the patients and patient advocacy groups and empower them to really ask for it. Just like when you go and you want to know what's your stage of cancer at the diagnosis, you want to know, do I have an NGS? Can I get one? And if not on solid tumor, can it be done on liquid biopsy? And based on that, am I eligible for a clinical trial? I would want every patient everywhere to take it in their hands and really fight for that and get that information, because that's priceless. And unless they ask for it, many won't have it. The second thing is to look at the providers and the healthcare physician, nurse practitioners, and allies that we have in the communities. It's difficult and it's time consuming. And if you don't have a trial at your institution, it becomes almost like a work for no reason, that you get all this information done and you know that your patient is not going to be able to travel 100 miles and get on a trial. On the other hand, matching those with trials, it's not simple, and it requires specific knowledge, was brought in the previous panel, of the education that we have amongst healthcare providers and how that education is not consistent. So my second message would be, let's empower the healthcare providers with the knowledge. So either build it as a curriculum in the hematology oncology fellowship. As we move forward, we train the new doctors to know about, and then build CME lectures through national meetings for all those participants to gain access. And then the last thing that helped us was really to our community engagement. So we have our university-based system. It's really built throughout, and we have several network offices. So we go in the middle of our communities, and we have communities with 70% Hispanics, and we have communities that are rich in Blacks. So our enrollment was heavier on the Blacks and the Hispanics. And when we look at taper, they actually get about 12% of Black participants. And overall, even though there are only 5% Latinas in Miami, we're able to get 40% or so. So my take on that is that when using culturally matched teams of providers, informed consents and information and brochures that are translated in every language, we promote the studies through every national and local TV in English, in Spanish. And then we have support groups and a coaching system for the patients that are also culturally matched. So those have been the strategies that we employ to be able to offer the patients, with the trial participation.
Thank you, Dr. Calfa. And the idea of empowering both patients and the clinical sites to do the recruitment that they need, to build on Dr. Patel's point, over recruiting to make sure that we get the right populations engaged is important. You both address some of the really substantial barriers to clinical trials, not just in terms of the trial design and enrollment, but again, to move past the identification of the problem and getting quickly to the solution. Let me move now to Dr. Gleed, so that we can understand from a policy perspective how we can address some of these things. And so Dr. Gleed, much of your work on healthcare is on healthcare access and delivery at the systems level. And today we talked a lot about precision medicine and how we can get precision medicine to patients. So do you feel hopeful or worried about our country's ability to provide equitable access to medicine's future innovations? And I know that's a little bit loaded, but let's go there.
Well, thank you very much, Dr. Green. I actually want to thank all of you for inviting me. I'm an economist, and in a room full of oncologists, I'm like the skunk at the garden party, but I appreciate your willingness to listen to my perspective on this. So at this moment, I'm actually feeling pretty hopeful. Equitable access to innovation, I think, as Dr. Brawley said, the first step towards that is getting more people covered by health insurance. And it's a really great thing that Congress and the administration seem to really be moving in that direction right now. They're also focused on containing people's out-of-pocket costs, and that is super important, both in terms of getting people access and in generating equity. So I think both of those things are causes for optimism. You know, is it challenging balancing act between incentivizing innovation and improving equity? As Dr. Brawley pointed out, he actually gave such a great example. Innovation is the thing that drives inequity often in these cases. Innovation in every way, even innovation in public health, as we learned with COVID vaccination. Anytime we have something new, it is easier for some groups to access it than others. So I don't want to pretend that this is easy or that we don't have tough trade-offs, but I think that focusing on it, being conscious of it, trying to navigate it and do better for groups that have been historically disadvantaged, this is something that's very much on policymakers' minds right now, and that is a cause for optimism.
And thank you so much. Anytime we hear about optimism, that's always a great thing, because indeed the innovation does provide the kind of hope that you speak of. But you also mentioned sort of a balance between the cost of care and providing high quality care, and balancing access to innovation. And so with that in mind, one of the things that ASCO has proposed in terms of at least balancing costs is looking at oncology clinical pathways, which when properly designed and implemented, do provide an opportunity and a tool to improve quality of care and reducing cost. And so I'm gonna take us now to the current administration, who has in fact stated that dealing with drug prices is a priority. But what do you think about the opportunities that the administration has to weigh in, and what will they or can they do in this area?
So there has been a lot of discussion about drug price controls. That is something that Congress has talked about a lot, is still talking about. Interestingly, the administration, not as much, I think, as Congress, but Congress sees a lot of money on the table, and they always are looking for money. And to be fair, we have a real problem with drug prices in this country that we're going to have to address one way or another. I think we are, and I think the big challenge here is that addressing drug pricing means weighing a couple of different kinds of trade-offs that are challenging for us. One is the trade-off between the profitability of drug manufacturing and the innovation that follows that profitability. So investors invest in companies they think are going to make a lot of money. And if they think the drug industry is going to make a lot of money, that's where they put their money. And that helps to get drugs, if not invented. I think there's a lot of dispute about whether actual real innovation comes that way, but certainly off the shelves. And that's what we've seen in COVID and in other things. So, but you know, the fact that there is that relationship doesn't tell us how much of it we want. We could spend all of our money on drugs and probably we'd have some more drugs, but it wouldn't be worth it. So this is a trade-off. You're having to decide how much of this good thing do we want versus this less good thing. And then the second question comes about by saying, okay, prices are really high, or what are we going to do here in terms of controlling the size of this market? And conventionally, the way we've controlled the size of the market is through cost sharing, is through requiring people to pay part of the cost of their drugs. That is a terribly inequitable way to do it. It's very unfair. It creates a lot of injustice. And so we need to think about other ways to do it. Now, one way other countries do it is just to not let the drugs in at all. Other ways to do it are to use different kinds of utilization management, other kinds of more individual-oriented kinds of quantity rationing, as I'd say. I think ASCO's idea, which I don't know a lot about the specifics of it, but thinking about how to design those kinds of mechanisms that get the right drugs to the right people and keep the wrong drugs from the wrong people in some way, right? That really make sure that we are using this extremely scarce resource efficiently. That's very promising. And one thing to think about is that the administration has the Center for Medicare and Medicaid Innovation, which is a center that is supposed to be trying out new ideas. And that may be a place where you can test an idea like clinical pathways and say, can we bring it to scale? Can we maintain equity in that kind of context? Can we produce the balance we need?
So being as innovative in our approaches to delivery and payment, if you will, as we are in our approaches to treating cancer is probably what's needed.
Absolutely. If we don't want to go to some very crude way of doing it, that's what's needed for sure.
Thank you so much. And I appreciate your point of view on costs. See, as an economist, it came in handy here. So great discussion. And then obviously, we've talked about a role for patients and how we engage patients and empower patients. We've talked about the role of the government in policymaking. And so Dr. Patel, I'm gonna give you the last question here and the last say before we open it up to the audience for questions. What can the individual oncologist do to ensure their patients have equitable access to precision medicine? What can they do to ensure that their patients have access and opportunity to participate in clinical trials? And really all of this is about ensuring the best possible outcomes for patients. How do we get there?
Yeah, so I'm going to start big and then I'm going to go small. One thing we can all do as oncologists and just as members of society is advocacy. I think Otis Brawley, again, bringing it back to some sage words, is equity really is a policy issue. And so ensuring that our patients have access to precision medicine, ensuring that we are not breaking the bank by paying for drugs that may not be efficacious, but certainly aren't being provided to patients in the way that they should be in terms of an equitable distribution. The participation in clinical trials, as I mentioned with the Clinical Treatment Act, ensuring our patients have any way of achieving the best possible outcome, we really must advocate not just for big policies, which I call big P, but also for the little policies, which is little p, local policies that can help us assist our patients in making fundamental changes to the system and ensuring what Isabel Duran mentioned earlier, the funding to support these changes that we're making from an infrastructural level. Locally, what we've done, and you've heard me talk about this, and then also the panel before, and then certainly in our panel now, is really working very closely with communities. So we are very extended in our clinics. So why there are certain services that we can essentially partner with community-based organizations to shift some of the collaboration so that our populations really do have the access that they need, the awareness of clinical trial opportunities, but also ensuring that these little policies are implemented. We can't wait for policies. So we really have to think about innovative approaches to work with our community organizations. We have an ongoing study in California that was actually state-funded, county-wide effort to ensure precision medicine access, not only in screening, but also once patients are diagnosed. And again, that was a policy that was implemented at the local level across the state that then led to funding to ensure that we can actually bring the treatments that we want to our patient population as well as the clinical trials. And then in our individual practices, what I like to do is take a time out and think about not only the pathways, what's the evidence base that may be there, who are other resources that may know best how to take care of this patient population, but also to do a clinical timeout, a clinical trial timeout, where I think about all the clinical trials that may be open for an individual patient and trying to match those clinical trials. Of course, in some communities where clinical trials aren't open, thinking about how to bridge those gaps to bring those trials to those individual communities is something I think we can think about as a whole in terms of our partnerships.
Dr. Patel, I think your analogy of boiling the ocean, you've found a way to at least address specific components of the ocean. And clearly some of the successes at the community level, at the practice level, hopefully we can learn some lessons from those and then be able to scale them more broadly so that more patients have access to precision medicine. Dr. Patel, Dr. Gleed, and Dr. Calfa, thank you all so much. We're going to take an opportunity now to answer some audience questions. And so, Jeanette, I'm going to turn it over to you. If we have any questions for our panelists, we can go ahead and start.
Thank you, Sybil. I'm going to start with a question for Dr. Gleed, building a little bit on what she mentioned before, as well as what Dr. Patel mentioned about that funding. We heard that there's an appetite in this administration and perhaps even in this Congress to act. But what do we do in the meantime to make sure, especially uninsured patients, are able to get the access to precision medicine? How do we demonstrate a return on investment, perhaps at even a local level, to get that funding to make sure that uninsured patients can get the care that they need until we have something at a national level?
So one thing I would say is that in most of the country, most people who are uninsured are probably at this instant in time eligible for coverage. That is not true everywhere, but right now, at this moment in most of the country, it is true. So one thing to do is to actually see about getting people coverage. And I want to put that first because although for patients with cancer is the thing on their mind and your mind at this moment, it's often not the only thing that's wrong. And getting people coverage means that they have access to the full suite of medical services, whereas cancer-specific solutions are only going to address that particular problem. So I think that's really important. I think that beyond that, what we want to be doing, first of all, is advocating to get more people coverage, because I think that is really key. And then we're going to have to be working with the charity care programs and other things that are very hard to navigate. I mean, they are a really poor substitute for coverage, but they are where we are in some places in the country right now.
And I can take a stab too, while we wait for payer reimbursement to meet us where we are, that's where these innovative partnerships really come up. So thinking about the local payers, for example, in Monterey County, where we have an agricultural farm working population, we really rely on our Medicaid, our local Medicaid organization, to help to reimburse the community health workers that are conducting the services. We also think about interesting advocacy organizations that may have funds available to pay for the precision medicine treatments while we're waiting for that to also be paid for, but then also ensuring that there's access, for example, with the institutions. I think going back to what Dr. Polite mentioned in terms of the trust issue, how do institutions engender trust? It's really on the institution level. And again, it's not a patient issue, but thinking about these institutions and their NGS and incredible technologies to be able to provide to those local communities, how can you think through innovative solutions with the funds that may be available while we wait for the big policies and local policies to follow?
Great, thank you. And I think we have time for maybe just one more question, building again a little bit on what Dr. Patel just mentioned, and a question to her as well as Dr. Calfa. If you could speak on your thoughts on physician engagement around communication styles, particularly to overcome some of those issues. There was an example given that Asian Americans have the highest insurance coverage in the state of Massachusetts, yet still show the lowest screening rates, and that tends to be a national trend. So perhaps speaking to how physicians can become engaged with those local communities to help address some of those disparities.
Right. The biggest lesson I learned delivering care, I've always been very interested in end of life and engaging in these conversations that for me have been challenging and for most very challenging. And what I heard from patients when we conducted a large focus group is that patients felt more comfortable speaking with peers than they did with their clinicians. And that's where the concept of utilizing peer navigators, for example, in the VA, we use veteran volunteers that can speak that same language. Isabel Duran brought up the language issues, and there have been multiple studies across the board that have demonstrated patient outcomes improve when the doctor speaks the same language, looks the same as them, be it woman, man, from low income households, race, ethnicity. When you share that same cultural and linguistic language, I'm using that kind of as a big language, a motif of language, you have better outcomes. And so I don't speak the same language as all of my patients, but how can I utilize volunteers or peers who can help us to do that and to bridge those gaps and improve that communication? I definitely think we need communication training, which ASCO has done really nicely in terms of the training resources that they provide to all of us. But we really need to think also about extenders and not our typical extenders that are in the medical community, but demedicalizing some of this communication so it really does match the cultural and linguistic barriers that we face as physicians when we try to provide optimal care.
And Dr. Calfa, being down at the University of Miami, so many different nationalities and ethnicities coming into Miami. Is there anything that you want to add to that?
We're really trying to find the right match for every patient. And just like Dr. Patel was saying, from the team of providers to really matching them through the support groups. And we have social workers and psychologists that have developed this coaching program where patients are really trying to be matched the best possible way. the minute we have somebody that is relatively in the minority participating in the clinical trial, we try to feature them and spread those words through support groups around the county and then on newspaper and social work and social media. So this past weekend, we had in the Miami Herald on the front page a patient, then even though she was just a white Caucasian woman going through pregnancy-related breast cancer treatment, she went on a clinical trial, and the phone hasn't stopped ringing since then. And the requirement was to go on Spanish television and talk more about it. Since then, we got 10 patients lined up from the Hispanic community to go on trials. So we use every venue we can to really spread the message out there. I want to make one point about the cost and about how pharma companies can help us, because I've seen the message there. And I think the positive studies are as important as the negative. I saw that where the reporting on the studies are really not as much as it should be. I want to say that TAPOR had reported on 6 negative cohorts and 9 positive ones, and 8 are under evaluation. So the negative ones taught us the lesson that those drugs probably should not be used even on a compassionate use. And that's a mechanism to really save the money where they don't need to be spent. So the pharma companies have been generous and partnering with us, and I think that's the best support that they can give us. Really become our allies in developing the trials and giving the drugs for free to the clinical trial participants. So that has worked really well for TAPOR and other studies.
Thank you, Dr. Calfa, Dr. Patel, Dr. Gleed. This has been a very insightful discussion, and I want to thank all of the panelists today for a very interesting and robust discussion. Certainly, this isn't the end of it, but I'm going to turn it back to Dr. Pierce for now to close out today's program. Thank you all so much.
Well, I too sincerely thank all of our invited panelists. What a great day, what a great panel this has been. And I want to thank the audience too for joining us for today's program, and also for providing great questions. And I hope you all feel like I do that this has been an informative set of discussions, and that the roundtable really provided insights and inspiration toward achieving equity in precision cancer care. We clearly have outlined that change is going to require a comprehensive approach, including policy solutions to guarantee access and ease adoption of new diagnostics and therapies, and also insurance programs that support and incentivize high quality, equitable, personalized care. I think that came out loud and clear in that last panel. ASCO is heavily engaged on both of these fronts. We've worked aggressively to secure passage of the Clinical Treatment Act, guaranteeing Medicaid coverage for routine clinical trial costs, and that was just a huge win for our patients. We're working with Conquer Cancer, the ASCO Foundation, to fund innovative research on cancer care equity and support the work of young and minority clinical researchers. And we're collaborating with the Association of Community Cancer Centers, ACCC, to test practical solutions to increase screening and participation of minorities on clinical trials. So I'm really encouraged by today's discussion. It's clear that we know how to fix the problem. We just now need the will collectively to take the next step. And for information, more information on ASCO's Health Equity Initiatives, I encourage you to visit asco.org/equity, where you can also find a copy of this recording, which will be posted in the near future. So we're at the close of our time, but again, I want to thank you all for joining us, and have a great day. Thank you.